Thank you very much. My name is Abdullah. I'm an interventional cardiologist from Barak Hospital in Kuwait. I'll be talking about catheter therapies for moderate and high-risk acute PE. So my learning objectives of the talk is to start from where Ali ends. First, we're going to discuss briefly the extent of the problem and the need for novel therapies. And then we're going to discuss the catheter therapies for PE, which included catheter-directed thrombolysis, ultrasound-accelerated thrombolysis, and mechanical thrombectomy that comes in two flavors. So this is a cohort study from Portugal, which is published this year, February of this year, looking at patients with high-risk PE over a period of 8 years. And they looked at the outcomes and the treatment received for this patient. And you can see here that the mortality for this patient is more than 60%. Now, with acute MI shock, we have lower mortality than that. That's even before the advancement of mechanical circulatory support. So 60% mortality is extremely high. And despite being high risk, only less than 1/3 of these patients received the thrombolytics, either due to absolute contraindication, relative contraindication, and sometimes it's just the physician fear of bleed. So on top of that, we have long-term adverse outcomes associated with thrombus burden and with PE, like post-PE syndromes and chronic thrombopulmonary hypertension. So there is really an unmet needs between what we have in PE treatment and what we need. Catheter-directed thrombolysis. So the idea of the catheter-directed thrombolysis is to reduce the risk of bleeding and delivering lower dose thrombolysis to the pulmonary embolus. There are two widely used catheters for that, the Craig-McNamara catheter and the Unifuse catheter. The same idea. It's a tube with multiple holes. You deliver it to the pulmonary artery and you infuse a low-dose thrombolysis. Few trials evaluated that, very small trials looking at mainly at RV and LV ratio reduction and pulmonary artery reduction and safety endpoint in terms of intracranial bleeding or life-threatening bleeding. This trial evaluated this technology in 24 patients, around 12 patients in each arm, and there is a significant improvement in RV-LV ratio and pulmonary artery pressure. However, the following year in 2022, we have the Canary trial, which is a larger trial looking at 94 patients with a similar design. However, it came as did not meet its primary endpoint, as the p-value was not statistically significant. So in summary, these two trials has conflicting results in terms of the value of catheter-directed thrombolysis in RV to LV ratio reduction in patients with submassive PE. Then the ultrasound technology came in, the ultrasound-accelerated thrombolysis, with an idea is to break the thrombus and to facilitate the lytic process by thinning and separating the fibrin strands. It's done through the ECOS catheter by Boston Scientific, and this trial evaluated that, comparing the ECOS system to the standard of care, which is heparin. There was a significant reduction in the RV to LV ratio at 24 hours. And following that, we had a single-arm prospective trial, the Seattle 2 study, which looked also on, evaluated 150 patients looking at RV to LV ratio reduction, pulmonary artery improvement, and decrease in the thrombus burden. And there was around 25 to 30% reduction in all these outcomes. But when we compared the catheter-directed thrombolysis to the ultrasound-assisted thrombolysis, there was no difference in terms of a pulmonary thrombus assessment at 48 hours between these two technologies. So really, with the catheter thrombolysis or the ultrasound-directed assisted thrombolysis, we don't have any solid evidence or to support the usage of these technologies. The outcomes are conflicting, some of them positive, negative, and these studies were done in patients who has no contraindication to thrombolysis due to bleeding risk. And as Ali mentioned in the previous presentation, that with acute thrombolysis works very nicely. But once, with time, the thrombus gets changed with collagen-rich fibrotic material, and the fibrinolysis does not work so nicely. And there is a big discrepancy between the reported onset of symptoms, like 90% of patients who reported acute or subacute symptoms, when they were evaluated with MRI, had an old thrombi evidenced by MRI. So now we are looking at the catheter-directed thrombectomies. We have two systems available, the Indigo system, the Penumbra, which is available in different sizes up to 16 French. It's a mechanical pump with a computer-assisted technology to try to reduce or minimize blood loss by sucking the thrombus when there is a contact with the thrombus. This was first evaluated with the Extract PE trial, which is a single-arm trial looking at submassive PE and evaluating the primary efficacy outpoint at which was RV to LV ratio reduction at 48 hours, and the safety endpoint was device-related complication and major bleeding. There was a significant reduction in the RV to LV ratio at 48 hours, 27%, with only 1.7% major adverse events at 48 hours. And the procedure, not the procedural time, sorry, the mean suction time or the Indigo time was around 37 minutes, and the patient's median ICU stay was around 1 day. Then we had the Strike PE data, which is planning to enroll 600 patients, the interim analysis of 150 patients, which majority included massive, submassive and PEs, showed significant reduction in RV to LV ratio with 2.7% major adverse event rate. So very promising result. And currently, they are enrolling patients in the STORM PE trial, which is a randomized controlled trial comparing the computer-assisted vacuum thrombectomy, the Penumbra device plus anticoagulation, compared to anticoagulation alone in patients with intermediate to high-risk PE, targeting more than 100 participants in up to 25 sites. The second device we have is the flow retrieval system by Inari Medical, which is a 24 French system introducer, and with a catheter up from 16 to 24 French catheter. It's not available in the region yet. The Penumbra is available in the region and it's been used in multiple countries. The flow retrieval is, the suction is done through a large syringe with a manual suction, and then you are able to return the blood using a flow saver device. This was evaluated with the FLAIR study. Again, most of the PE trial, you notice that they look at the RV to LV ratio and device-related complication and major bleeding in terms of safety outcome. There was a significant reduction in RV to LV ratio with the Inari arm without increase in bleeding. Then we have the FLASH registry, which is a very large registry, including more than 50 sites in the United States and more than 800 patients, majority intermediate to high-risk PE, and 8% of them, they were high-risk PE. There was around 8 millimeter of mercury drop in the PA pressure, 1.8% adverse events, and 75% of patients had no or mild RV dysfunction at 48 hours post-intervention. So very promising result. Following that, we have the FLAME study, which is a prospective study looking at high-risk patients. And this is the first registry looking exclusively on high-risk patients, because you notice from the previous registry, they looked at intermediate to high-risk and high-risk. And they compared it. They compared the patient on the flow retrieval arm to a context arm. The context arm, they received like a standard of care, either systemic thrombolysis, catheter-directed thrombolysis, surgical thrombectomy. So basically, it was left to the physician's decision. And comparing the primary outcome, which was the primary endpoint, was 17% in the flow retrieval arm compared to 63% on the context arm. And if you look at in-hospital mortality, is around 30% in the context arm versus 2% in the flow retrieval system. Recently, we got the result of the Peerless trial. Peerless trial was published, the result was published last month. And the PEERLESS trial randomized patient to either flow retrieval arm compared to catheter-directed thrombolysis. And they looked at the primary outcome of a win ratio with the 5 components. And if you have a win ratio of 5, then it will meet its primary endpoint. The primary endpoint occurred significantly less frequently with the large bore mechanical thrombectomy, i.e. the Inari arm, compared to the catheter-directed thrombolysis arm. Dr. Ali shared with us one of the cases that he done in Montreal, Canada with the Inari system. This is a 7-year-old gentleman admitted with a left MCA stroke. He had a PA arrest, CPR, ROSC achieved in 7 minutes. They had a pair team established there. They had a pair team meeting, and the patient deemed to have an absolute contraindication to thrombolysis. The patient was on maximum support and pressors, so they decided to go on with a mechanical thrombectomy. So you can see here, this is the thrombus burden pre. And this is the snake that they aspirated from the PA, and this is the final result on the pulmonary tree. There was a significant improvement in the PA pressure. The systolic pressure dropped from 61 to 30 millimeter of mercury. So you can see here that over the past 10 years, we had around 7 or 8 trials in PE, and currently we have almost 7 or 8 ongoing trials for PE. So the literature and data for PE is growing rapidly, and in the next few years we're going to have wealth of data to tell us about how we're going to manage these patients. Thank you very much.